to May to the May 9th Echo. We're so glad you could make it. If it's your first time with us, we'd love to meet you. So please put your name and where you're from in the chat. Today we have our didactic is going to be co-presented by myself and Dr. Lori Tam, who's the medical director at Providence, Portland Cardiology, and she's a preventive cardiologist. And we're so fortunate to have her. And then there will hopefully be time for some discussion as well. So a couple Zoom reminders. Please rename yourself first and last in the clinic. Um, you guys are very seasoned with this, as we all are since COVID, but please mute your microphone if you're not speaking. Turn your video on if you can. Of course, we understand if you can't. If there are multiple people in the same room, then list multiple names in the chat. As you know, this is CME accredited. So for all University of Washington faculty, staff, or students, you can register through this mobile text registration and sign in. And then after registration, text 10085 to the number, and you should receive a response stating thank you, and we've recorded your attendance for this echo. Don't worry if you're not affiliated with the University of Washington, because we can capture your CME and provide CME through a different mechanism. So for all other attendees, your attendance will be recorded by Sammy and also through our Zoom analytics. So in order for us to do that, we need to see your full name. And if Sammy needs to clarify anything, she'll reach out via chat. There are so many fantastic CME accredited echoes that are ongoing for Washington State healthcare providers, such as University of Washington Project Echo Geriatrics, which meets the third Friday of each month, University of Washington Traumatic Brain Injury Behavioral Echo. There's a Psychiatry and Addiction Echo, and a Telebehavioral Health series as well. If you have a patient that you're managing with complex pain medication, especially high dose opioids, this telephone consultation line here, 1-844-520-PAIN, is fantastic. And there's also a case conference through the Telepain series, which meets on Wednesdays from 12 to 1:30. If you haven't filled your education cup enough, there's also neurology and psychiatry grand rounds, which are available via Zoom and also through an archive, as you see here and here. These are wonderful resources as well. And this is very new, and we're very excited about this opportunity. So I'm going to take a moment to describe this bold grant opportunity. So this is an opportunity for providers within federally qualified health centers and rural health centers. And there's money to support your effort to engage in ECHO in a deeper and very specific way. And the funding is, as you see, $4,000 per program for a total potentially, if you receive both, of 8,000. So the participation would be in cognition and primary care, or in Project Echo, or both. And there are requirements which are detailed in far more granular detail through scanning the QR code and on the website. But just briefly, to participate in cognition and primary care, it's the health system who would participate, and they would adopt the EHR toolkit, which Dr. Brock Gassler has spoken about here, participation in the cognition and primary care training, and then some data collection. And if you're participating through Project Echo Dementia, then we are asking you to watch and take a post test for our top 10 didactics, our sort of core dementia didactics. We're also asking that you attend over half of the live sessions and bring forth 2 case presentations, and then also for some data collection. So this is live. Scan the QR code and look at this. The application is less than 2 pages. And please do also share to any colleagues at FQHCs or rural health centers who you think may be interested in this. And as you see, the applications are open through June 30th. So if you want to speak further about this, connect with our fantastic program manager, Samantha LaFontaine, or Sammy. Also, please do continue to bring forth your cases. We really learn so much through case-based learning. That's sort of at the core of ECHO. And so, connect with Sammy, and there's no case that's too complex or too simple, or every case has an opportunity to take a deep dive, to learn together, to share what's going well and to share the challenges. And then after you bring the case forward, you receive, as you see on the right, this kind of recommendation that responds to the questions that were raised, and then is really something that we as the hub team meet to discuss and create an action plan going forward for you. And then Chris and I are available should you have further questions. And you can always bring your cases back after, incorporating some of the recommendations. And we're happy to continue to learn together with these case-based presentations. As we know, there's no PHI revealed, so we don't display anything that could reveal the patient or the family members. And remember, all sessions are recorded, and please do complete that 1-minute survey, because we can improve the process based on your feedback, and we want to continue to do that. As we said, there's accreditation through University of Washington for CME. There are no financial disclosures for this presentation. Here's our hub team. As you see, it spans many health systems. And then I just want to take a moment here to express our gratitude and thanks to Dr. Mimi Pattison. And Mimi Pattison, as you know, was on our hub team from the very beginning. And she is the medical director, former medical director for Franciscan Hospice and Palliative Care. And she's given a number of lectures that are linked here. There's 5 total. And I really, she helped us to think about the quality of care, the goals of care, and particularly at the end of life, and how to really help support families. And I'm sure if those of you who were there may recall vividly her teaching, because it was so practical and useful. So we just want to express our deep gratitude. She's moving on to spend time with her family. She's taking a step back away from her clinical and administrative responsibilities. We wish her all the best, and she will be missed. And she's been such an integral hub team member since the inception. And we just quoted on the right, people's feedback from her talks. And great lecture. I'm going to incorporate this. We want to see more presentations. And she's always welcome back. So if we could all just send our gratitude and thanks to Mimi in her essential role in palliative medicine and hospice care as our hub team member, that would be appreciated. She might even register that. Who knows? Okay. We want to continue to grow, and we have grown. We have over 1,700 instructional hours since the beginning in 2020. In 2023, 100% of our respondents reported that Project Echo Dementia improved their quality of care for patients with dementia. Nearly 64% reported changes by others within their organization based on their participation in ECHO. And we want to continue to build these sites out. So currently we have 96 sites serving over 250 zip codes with 243 providers. So fantastic. As I said, we don't have a formal case presentation, but hopefully we can have a really good discussion dialogue. Okay, so before I do this, I might stop the share, I think, and we can just check and briefly introduce ourselves and say one thing that we're looking forward to. Very concise, go to the kind of essence of what we're looking forward to doing this weekend. So is as she said, the medical director for the women's cardiology program at Providence Portland. And I will stop my share. And thank you so much for joining us and speaking to us today about women and heart disease.
Happy to. So thanks for having me. I'm going to make sure my share is visible to everybody. Can you see that?
Perfect.
Should be sharing. Good. Perfect. All right. So today I'm going to take this opportunity to talk a little bit more about heart disease in women. We're going to talk about atherosclerosis, menopause, and then prevention of heart disease in women. So I have no financial disclosures. Let me go ahead and just make sure the next screen is up. You guys are not seeing the next, let's see, there we go. Perfect. Okay, so no financial disclosures. So today, in terms of learning objectives, we're going to talk a little bit about the epidemiology of heart disease in women in the United States, talk about the pathophysiology of atherosclerosis, the role of lipids, and specifically on ApoE and cardiovascular risk, also the impact of menopause and heart disease risk, and the role of hormone replacement therapy. And then we're going to talk about risk assessment, coronary calcium scans, additional lipid testing, and lifestyle choices to reduce cardiovascular risk. So I think, as many of us know, heart disease is the number one killer of both men and women in the US. And, we know that that heart disease kills more than the combination of all types of cancers combined. And the combination of heart attacks, heart disease, and stroke kills 1 in 2 women in the United States every year. So, when we talk about heart disease specifically in women, we know that heart disease is a leading cause of death. But women tend to get it, at a little older age, even though, we have the protective effects of our natural estrogen. And then after menopause, we see heart disease risk go up. And for a number of years, actually in the last 20, 30 years, more women have died each year from heart disease than men, which is a surprise to many. But so heart disease is a woman's disease, although over the years we've traditionally thought of it as a man's disease. We do get heart disease. We just tend to get it a little bit later. Sometimes it presents a little bit differently. But there's so much we can do in terms of public health, in terms of empowering people with the knowledge and the tools to live a healthy life, and then also making sure that our providers are aware of this risk in women and treating. And women traditionally have been undertreated. We haven't given women statins as aggressively. We haven't kind of worked up their symptoms as aggressively. And because of that, that's part of the drivers of the higher risk of death in women with heart disease. So I'm going to talk about atherosclerosis because far and away the major cause of coronary artery disease, heart attacks in this country are related to atherosclerosis. Now, women get other types of heart attacks as well that's not related to atherosclerosis. For example, spontaneous coronary artery dissections, vasospasm, microvascular disease. But atherosclerosis is certainly the predominant kind of pathophysiology behind coronary artery disease in this country. So we've got, on one part of the screen, this normal coronary artery, which has got a nice layer of smooth muscle, nice smooth endothelium. As we age and lifestyle and other habits kind of come into play, the artery gets narrowed with atherosclerotic plaque, and you get this kind of collection of lipids and cellular debris and calcium that gets kind of encapsulated by this fibrous capsule, but starts to build in and fill in the lumen of the coronary arteries. And this is the cause of angina. This can be a cause of heart attacks, especially if that plaque ruptures and it becomes irritated and you get clot on top of that plaque. That's usually when arteries close up and people present with acute heart attacks. So when we talk about atherosclerosis, we also want to talk about, risk factors, and one of them is cholesterol buildup, and that's the soft fatty-like substance found in the bloodstream. It's in all of our blood cells, and our cholesterol really comes from two sources. We know that it's made in your liver, and it's also from the foods that you eat. I will also say that the majority of the cholesterol in your system is actually made in your liver. So yes, dietary and lifestyle things do make a difference, but some people are just predisposed because they make too much cholesterol and they don't have kind of the normal receptors to clear that cholesterol from their bloodstream. And this results in excessive levels of cholesterol buildup. So when we talk about cholesterol, I also want to make sure we understand kind of what that cholesterol number is. So we know that we give people a total cholesterol number score that's made up of a calculation of the number of HDL in your bloodstream, so good cholesterol plus the LDL, which is the bad cholesterol, and it's 20% of your triglyceride levels. So people can have a high total cholesterol number, But if it's driven by a high HDL and the LDL is not that bad, well, that total cholesterol is not that concerning. So the total cholesterol matters less to a cardiologist than the actual breakdown of your cholesterol, types of cholesterol that you have in your bloodstream. So patients who have a lot of high HDL, good cholesterol, less worrisome. It's protective up to a certain level anyway, and then because we know that it's kind of got this bi kind of modal distribution. People who have low HDL have more cardiovascular events. People who have really excessively high HDL, like greater than 100, have more cardiovascular events. So you want a high number of good cholesterol, but not overly high, not above 100. And then we know that LDL really has been our target for a number of years in terms of reducing risk for atherosclerosis and cardiovascular events. LDL is the bad cholesterol. And one good way to remember is L is for lousy, H is for healthy. So you want lots of, high, good, healthy cholesterol and not very much of this lousy, bad cholesterol. And usually with LDL, the lower the better. All of our cardiovascular studies over the last several decades have shown that if you can drive the LDL lower, you're going to reduce cardiovascular events, strokes, heart attacks, etc. So for many of our patients, we want an optimal LDL of less than 70 if they have underlying cardiovascular disease or atherosclerosis, if they've had a stroke, if they've had a prior stent, or even if they have some silent atherosclerosis where they may have some plaque or cholesterol buildup in their coronary arteries that you see incidentally on a CT scan. They haven't had their cardiac event, but you want to get that LDL less than 70 to prevent disease or plaque progression. We make that same recommendation for patients who have significant coronary calcification and a high coronary calcium score. In those patients, to be aggressive with prevention, we'd recommend an LDL goal of at least less than 70. Some of the newer European guidelines are now more aggressive. So in really high risk patients, they recommend an LDL goal less than 50 or 55. We've not yet adopted it in our country in our guidelines, but I think it may be coming that our goal really is to get that LDL level down. So your total cholesterol is a makeup of all these three elements, but we really care about in terms of cardiac disease prevention is what your LDL numbers are. So in terms of looking at the types of your cholesterol particles, we have the LDL, which joins with fats and other substances, and this builds plaque in your arteries. The HDL, the good cholesterol, carries harmful cholesterol away from your arteries, helps you clear the bad cholesterol. And in general, an HDL number of less than 40 is associated with increased cardiovascular risk. And then we want to talk a little bit about apolipoproteins, which is what ApoE is one of these things that we're going to talk about. We're talking a lot more about apolipoproteins in recent years because we now have more information in terms of using that to help stratify a person's cardiovascular disease risk. So apolipoproteins are found on the surface of lipoproteins. So lipoproteins are like LDL, HDL, these are the cholesterol particles. Apolipoproteins are these additional proteins that are on the surface of these lipoproteins. So this is that green stuff on top of your lipoprotein and in this diagram. But it affects the transport of lipoproteins and it influences the uptake and clearance of lipoproteins. So your apolipoproteins will affect whether you're able to effectively clear the cholesterol, the bad cholesterol from your system, whether you're able to take up good cholesterol. So apolipoproteins are now becoming a greater part of discussion. You'll know that different screening criteria have come out, and for some patients, we're screening lipoprotein A. We're also screening for apolipoprotein B. Those, if you have higher levels, are associated with increased cardiovascular risk. Many of these things are genetically driven, especially the lipoprotein A. So for someone who's got a strong family history of premature coronary disease, sometimes we'll screen them for lipoprotein A and their ApoB levels to kind of assess their risk to see if they have the genetic marker that would suggest increased cardiovascular risk, because that would drive more aggressive efforts at prevention, whether it means starting their statin earlier or being more aggressive with lifestyle interventions to help reduce the risk over time. So I'm going to talk a little bit about ApoE because there's this big connection between ApoE and association of dementia. People who have high levels of ApoE have higher risks of dementia. We know that patients who have a certain type of ApoE, ApoE4, is associated with also increased LDL levels and total cholesterol levels. So these patients who have, there's different types of ApoE, you've got different alleles. So there's E2, which is actually protective and it decreases cardiovascular risk. ApoE3 E3 is the most predominant kind of form in the population. So we use that kind of as our marker in the middle. But people who have increased expression of this ApoE4 have higher numbers of both total cholesterol, higher levels of LDL, and lower levels of HDL relative to people who are the kind of the reference in the population, which would be ApoE3. So number patients who have predominantly ApoE2, you can tell, is actually lower. They tend to have lower total cholesterol, lower LDL levels, and kind of a not a significant change in terms of HDL levels. But we know that ApoE4 increases cardiovascular numbers in terms of LDL cholesterol and total cholesterol numbers. Now, we also want to look importantly, does ApoE4 associated with increased cardiovascular risk, and that is true. So, this is a study that pointed out that patients who have higher levels of ApoE4, they have a higher odds ratio of coronary artery disease. And individuals that are, have predominantly E2, it's more protective. But when you have the expression of E4, ApoE4 as your allele, especially if you're homozygous, two copies, the odds ratio is at least 1.2 times higher for coronary artery disease relative to the standard population with E3. So, there is clearly some association with ApoE4 and increased cardiac risk. Here is kind of a schematic looking at E3, E2, E4, and people with higher levels of E2 expression, they have higher HDL levels, and then if you look at ApoE4, these patients have higher LDL cholesterol levels, they have more erythrocyte homeostasis, more complement activation. So some of this inflammation that drives plaque buildup that is actually more key than just cholesterol numbers, and then an increased activation of the coagulation cascade. So you'll see that these patients have, more of the yellow, which is the LDL cholesterol, less of the blue, which is the HDL cholesterol, and kind of more plaque irritation, inflammation, and progression. As we now understand atherosclerosis a lot better. We used to focus only on cholesterol numbers. We know that that's not the case. That inflammation drives plaque deposition. And essentially, I describe it as making your cholesterol more sticky. People who have a lot of inflammation in their levels, high CRP levels, for example, they get a lot more inflammation in their arteries. Their plaque is more likely to stick and form deposits. So that's why, occasionally we'll have someone who comes in with, pretty normal looking cholesterol. They might have like an LDL level of under 100, total cholesterol is like 180. They're like 50 years old and they're like, Doc, how'd I get a heart attack? My cholesterol's been good. But many times those patients have genetic predisposition. They might have an elevated lipoprotein A. They might have elevated ApoB levels, maybe ApoE4 if we were checking for it, and they often have higher CRP levels and other issues that drive inflammation. And it's the inflammation that makes the cholesterol more sticky, more prone to plaque progression, not just the total cholesterol, LDL cholesterol alone, as the main driver of atherosclerosis. And that's why, statins have been beneficial for treatment of preventing recurrent coronary events or even first coronary events in patients who have high cholesterol. And it's not just for cholesterol, it's really because statins decrease inflammation. The Jupiter trial a number of years ago, 20 years ago almost now, told us that, statin cholesterol medicines don't just lower the LDL, they lower CRP, they lower inflammation. And we think that that's what reduces cardiovascular events. So I'm going to switch gears a little bit and talk a little bit about specifically, menopause and impact on cardiovascular risk. I treat a lot of women patients with heart disease, and we know that there are certain hormonal changes that happen around menopause that increases cardiovascular risk because with that decrease in natural estrogen, we know that there are certain metabolic markers that change. So one is that you have an increase in LDL levels, a decrease in HDL levels. And I see this all the time with our patients that are postmenopause. They'll tell me, I eat the same, I exercise the same, I do everything the same, but why is my LDL numbers, where are my LDL numbers going up and my HDL numbers going down? Well, that's the effect of losing some of this natural estrogen and the beneficial protective effects that you've had all these years. Women also tend to have more weight gain, especially central adiposity, which is worse for in terms of cardiovascular risk. We see a rise in blood pressure, a rise in insulin resistance. You're going to start seeing more prediabetes and diabetes metabolic syndrome in this group. And women who experience early menopause, age less than 45 years, are at higher risk for cardiovascular events. Women who experience premature menopause, usually onset less than age 40, are at significantly higher risk for cardiovascular events. So these are things that we want to pay attention to when you're taking care of our women patients, especially through this stage of life. So I'm going to talk a little bit about, so if estrogen, your natural estrogen is good for you, can we give you hormone replacement therapy and decrease cardiovascular risk? And there's lots of data that's changed in the last few years on this. Initially, women were on hormones for a long time. And people didn't realize that it increased certain cardiovascular risk factors and stroke and stuff. And after that became more aware, we kind of took a lot of women off hormones and said, nope, no hormones. And now, kind of more recent studies have said that, well, there's a window in there when you can probably still safely treat women with hormone replacement therapy if they need it. And that usually is in younger women, so women that are within 10 years from onset of menopause and women who are less than age 60. So there's actually some studies that have shown a decrease in coronary heart disease in women that you're treating. There's a bit of a cardiac protective benefit if you're treating younger women around the time of menopause. But that benefit starts to go away and it becomes more of a negative aspect if you're treating them beyond age 60 or more than 10 years from onset of menopause. So the moral of that story is that older women shouldn't be on hormone replacement therapy. If you need to be on hormones for vasomotor symptoms to kind of get through the perimenopause stage, younger women, it's probably still appropriate in women who do not have known atherosclerosis or coronary artery disease, and women who do not had any blood and clotting disorders or strokes and things like that. So if it's really just for women for pure prevention alone, we don't recommend it. So, but if you're having symptoms that make it reasonable to start hormone replacement therapy, it's still reasonable. The American Heart Association guidelines say you don't want to start HRT alone for the purpose of cardiac protection, but it's reasonable if you're needing it for hot flashes or sleep or other issues that women get around perimenopause. And we don't recommend it. Hormone replacement therapy is not recommended in women older than age 60 or more than 10 years from onset of menopause. After about 5 years, we want to start weaning women off. We know that treatment beyond 5 years is associated with increased risk, both cardiovascular risk, stroke risk, clotting risk, and breast cancer risk. But it's not recommended, HRT is not recommended in women who've actually had blood clots, known breast cancer, known coronary artery disease, uncontrolled blood pressure, or active liver disease. But there is certainly a group in the population which may benefit if they're having certain symptoms, and hormone replacement therapy is no longer off the table for everybody. But reasonable if you're starting it in younger women to get them through the changes and the symptoms that they have around that time. So that's our little kind of discussion about menopause and cardiac disease risk. But I want to talk to you kind of about just all of your general patients that you see. You want to do an atherosclerotic cardiovascular disease risk assessment. So, in patients who already have known ASCVD, meaning they already have known atherosclerosis, they've had stents, heart attacks, blockages, if they have carotid disease and they've had strokes, if they've had any sort of known atherosclerosis, we want to treat them with statin therapy. So, they should be on. And in most of these patients, an 81 milligram aspirin is also indicated. Now, we don't recommend aspirin for prevention in the general population if you do not have known atherosclerosis. A big New England Journal article came out several years ago that changed our practice. Years ago, we would put women, everybody, on aspirin, over age 60, 65 to prevent a heart attack or a stroke. And we stopped doing it for the general population unless you have known atherosclerotic cardiovascular disease, because that study demonstrated an increase in bleeding risk, especially in GI bleeding, with just putting everybody on an aspirin. So now we pick and choose these patients. And if they have known atherosclerosis, previous events, and known atherosclerotic disease, we'll put them on an 81 milligram aspirin. But for patients in which you do not know whether they have ASCVD or not, then we recommend making sure that we screen our patients. So after age 20, you want to get at least an initial evaluation with the lipid panel. And if the cholesterol numbers are fine, you want to recheck it probably every 5 years. If the cholesterol numbers are elevated, we'll check them more frequently as we counsel them on lifestyle and dietary changes to try to improve those numbers. But if your LDL is greater than 190, the guidelines suggest that we need to treat all these patients with a high intensity statin to lower the LDL by at least 50%. So if your LDL is greater than 190, you should be on a statin. We should start treating those patients more aggressively. That's per the current guidelines on lipid management. So next I want to talk to you about is, for everyone else where they're not greater than 190. So, and you want to know, at least for our patients between the ages of 40 and 75, what's their risk for cardiovascular event in the next 10 years. So many of us are used to using this score. It's pretty easy. You can just Google it, but it's the ASCVD risk calculator that's well publicized at this point. And we use that to determine risk. It takes into account your HDL cholesterol, your age, whether you have diabetes, blood pressure, smoking history, all of those things. And it spits out with that calculator a risk. And if you're less than 5% chance of having a heart attack or stroke in the next 10 years of a cardiovascular event, you're considered low risk. Your borderline risk if you're between 5 to 7.5%. And you're considered intermediate risk if you're between 7.5 and 20% risk. And if your risk of a cardiovascular event, heart attack or stroke in the next 10 years is greater than 20%, we deem these patients high risk, right? So we know that how we treat you is really based on your risk profile. So if your risk of a atherosclerotic cardiovascular disease event in the next 10 years is less than 5%, we're going to counsel you on lifestyle changes, work on modifiable risk factors, quitting smoking, kind of all those things that we can change. If you're high risk, well, that's easy. If your risk is greater than 20% risk of heart attack or stroke in the next 10 years, we recommend starting you on a statin to lower that LDL by at least 50%. But it's this kind of intermediate group, when your risk of a heart disease, heart event, or a stroke event in the next 10 years is 7.5 to 20%, kind of in that intermediate range, you want to consider kind of certain factors that would help you decide whether you want to treat with statins. Usually, if above 7.5%, we will treat with statins at this point clinically. But there are certain things that you might want to assess to help you kind of solidify that decision, especially if you have patients who are hesitant to be going on a statin medication. So if I've got someone who's maybe, 8, 9, 10% somewhere in there, and they're like, I really don't want to go on a statin, then I'll talk to them about looking at risk enhancing factors, and we'll go over some of those. Some of that includes premature family history, a high CRP level, elevated lipoprotein A level, things like that. I also will consider a coronary calcium scan for these patients. So if they have no known history of atherosclerosis, no known actual events in the past, but I'm trying to decide kind of what their risk is, whether they need to be on a statin. Well, if I check a coronary calcium score and they've got a lot of silent calcified, atherosclerotic plaque in their arteries, this would be a patient that I would favor treating with a statin more aggressively earlier. And in these borderline patients between 5 to 7.5%, I will sometimes use that to help me kind of decide, especially if it's somebody who's got a family history of premature CAD. I want to look at that risk much, in a more refined way, not just looking at the numbers, but I actually want to look at your arteries and see if there's evidence of plaque buildup. And if there is already a lot of plaque buildup, then we know that we want to treat you more aggressively. So, in terms of these cardiovascular disease risk enhancing factors, so these are beyond just the numbers. These are things that would increase your cardiovascular risk and may support, kind of tilt the scale in terms of treating you more aggressively earlier, especially if you've got some borderline cholesterol numbers. And that includes premature CAD in the family, so males less than 55 years, females less than 65. A cholesterol number that's not quite, above the 190 where you would automatically be put on a statin. But if you're even in the ones LDLs in the 160 to 189 range, kind of makes us more concerned that you've got more of a cholesterol issue of concern. Patients of metabolic syndrome, patients of chronic kidney disease, chronic inflammatory conditions. So we know that patients who have underlying inflammatory issues like lupus and rheumatoid arthritis, the chronic inflammation from those conditions increases the risk of plaque progression and atherosclerosis. So if they've got underlying inflammatory diseases, and many of these inflammatory conditions, autoimmune issues are more predominant in women, we know that there's increased risks that are attributed to that. We talked about premature menopause before age 40 as a risk enhancing factor for cardiovascular risk. And then a history of pregnancy associated conditions that increase later risk in life for atherosclerotic cardiovascular disease. This includes the group of women that have preeclampsia, eclampsia, gestational diabetes, gestational hypertension, preterm labor, and even babies that are small for gestational age. We've talked about pregnancy as kind of like nature's stress test, and women who are younger having their babies, but having these pregnancy associated conditions, when you take a history later on in life, you want to take that into account because we know that those women are at higher disease risk later on. And in fact, I think it's a really good opportunity for education that women know that, your gestational diabetes, your hypertension now increases your cardiovascular risk. We need to work with these women, decades earlier to prevent kind of their ultimate presentation down the road with heart attacks and strokes later on in life. A lot of us have our babies and we forget about, the hypertension goes away or the gestational diabetes goes away, but that risk doesn't go away. You want to make sure patients understand that. There are certain high risk race and ethnicities, especially like South Asian patients, get a lot of premature coronary artery disease. So that would be kind of an additional risk enhancing factor that might steer me towards treating with a statin earlier. We also know that there are lipids and biomarkers that are associated with ASCVD risk. So patients have really high triglycerides, elevated C-reactive protein, which is an inflammation lab, elevated lipoprotein A. And as there's a relative indication to check this if someone has a family history of ASCVD, especially a lipoprotein greater than 50, is suggests increased cardiovascular risk. Elevated ApoB levels greater than 130, and then an abnormal ankle brachial index looking at kind of signs of peripheral arterial disease. So these are reasons that would make us a bit more aggressive in terms of managing these patients. We want to take that into account. So mentioned briefly about coronary calcium scores. I'm going to talk to you about that because this has been a tool that we're using much more in cardiology and in preventative care, and also now in primary care, kind of in assessing a patient's risk. Because someone who comes in to see me at age 45 or 48 and says, my cholesterol's a little high, it's not that bad, but my dad had a heart attack at 45. What should I do? I'm in my 40s now. So, maybe by ASCVD score, they don't quite meet criteria for statin initiation. But in that patient, I might do a coronary calcium score. And if their score comes back really high, for example, it comes back at like 90th percentile for age and gender, well, that means that out of 100 men in his age group, he's got more plaque than 89 of them. He ranks 90. So if that was you, I think you're me, I'd probably want to go ahead and start my statin now, not wait for the cardiac event to occur to then start them on the medicine or wait until I'm old enough for the ASCVD score to get high enough to be a problem. So this is actually a non-invasive tool. It's a quick little CT scan, kind of just from here to here. Takes about 3 minutes, non-contrast, no IVs necessary. They just lay down on the table, get this quick CT, and it tells me kind of their silent calcified plaque burden. And if you've got a lot of calcium deposits in plaque, it correlates with increased risk for cardiovascular events. So if you look at the figure, we know that patients who have coronary calcium score of 0, their risk of cardiovascular events in the next 5 years is extremely low. Now that next line, when you look at the red line, they certainly are at higher risk than someone whose coronary calcium score is 0. And then you look at the trend for patients of a coronary calcium score of 100 to 300, 101 to 300, they're at higher risk. And then the patients of a coronary calcium score greater than 300, there's a significantly increased high incidence of coronary events down 5 years. So within the next 5 years. And that is proven in a number of studies and trials now. So coronary calcium score is a very good predictor of your risk for future cardiovascular events. And we use that as a screening tool in certain individuals. Not everybody that comes in the door needs a coronary calcium score. If they're really low risk, there's no family history, kind of no other major risk factors, and the ASCVD score is low, less than 5%, I wouldn't advocate checking a coronary calcium score in these patients. But in the intermediate risk population or patients who have a premature family history of CAD, this might be a test that would help us identify their risk earlier so you can treat them more aggressively earlier. And not only is coronary calcium scores associated with high scores associated with increased cardiovascular events, we also know that coronary calcium score is also a predictor of all-cause mortality. I'm not entirely surprised because, of course, cardiovascular disease is the number one killer of men and women in the U.S. But if you have really high coronary calcium scores, your, cumulative survival over the next 10 to 12 years is less, and it's all in gradation. So the higher the score, the higher the mortality, all-cause mortality. So this is, I think, an important predictor of risk that we need to pay attention to. And I know that many more of my primary care colleagues are appropriately using them in patients. Now, if patients already have ASCVD, meaning that they already have a known coronary artery disease, they've had a stroke, those patients, they don't need a coronary calcium score. You need to treat them aggressively with a statin anyway. Patients who already have diabetes, usually I don't do a coronary calcium score because we all know the current recommendations that all diabetics should be on a statin anyway for prevention. So it's not adding anything, and I wouldn't run it if you've already got a known history of diabetes. But for patients who don't have known ASCVD, don't have diabetes, you want to assess risk in at least intermediate risk patients. This is reasonable to do. So, and in terms of what do you do with the coronary calcium score, if the score is greater than 100 or greater than 75th percentile for age and gender, usually we recommend statin therapy. And even in patients where it's like 50th percentile, 60th percentile, that's kind of a risk benefit discussion to have with the patient. It's not zero. Zero is quite good in terms of being a negative predictor of coronary events in the next 5 years. But if your score is, elevated at all, I at least talk to you about, oh, there's some early atherosclerosis, how aggressive do you want to be? But if you're more than 50th percentile, meaning that you've got more plaque than the average man or woman in your age group, I'm going to talk to them about whether they want to be on a statin. But if you're greater than 75th percentile or their score is greater than 100, a statin is indicated. And generally, if your score is greater than 100 or greater than 75th percentile for age and gender, you have silent atherosclerosis. And in that group, if aspirin's not contraindicated because of GI issues, bleeding issues, I would usually recommend an 81 milligram aspirin once a day in that group as well. But if your score is zero, if your cholesterol is a little high, but your coronary calcium score is zero, you may withhold statin therapy in that group unless they're an active smoker, they're a diabetic, or if they have a family history of premature CAD, I would still at least say your risk is still not zero. And then I would usually, in a patient with a score of zero with elevated lipids, in which we've just determined that we're not going to start on treatment or they decline treatment, don't need treatment, I repeat the coronary calcium score in maybe 5 years, somewhere 5 to 10 years, because we have to note that the coronary calcium score looks at how much calcified or hardened plaque is in your arteries. But you also have non-calcified plaque, soft plaque. So all calcified plaque was non-calcified at one time. Soft plaque over time hardens and becomes calcified. So if you have a coronary calcium score of zero, it means you don't have any hardened or calcified plaque at that moment, but it doesn't mean that you don't have some soft plaque that's in there that we just aren't capturing because it hasn't hardened enough. So in 5 years, I'll do another coronary calcium score just to make sure it's okay. But sometimes I'll see that the score went from 0 to 20, 30, 40, 50 because they had some soft plaque at that time that then calcified and hardened over time. And that person is still at risk. It's not zero at that point. They do have some signs of atherosclerosis. So you want to pay attention to that. So I'm going to close with talking about kind of a reminder of the kind of warning signs of heart attack. This applies to both men and women, but sometimes women may not experience chest pain during their heart attack, or they may not describe it as chest pain. So we want to make sure that all of our patients are aware that although chest discomfort is the most common presenting symptom with a heart attack, patients also describe it as a burning or a heaviness or a pressure or a tightness. They might think it's heartburn, acid reflux. They may not necessarily describe it as chest pain, but you can also have significant shortness of breath, lightheadedness, pain that radiates into the back, the jaw, the arm, the shoulder, significant palpitations, nausea, cold sweats, kind of unexplained fatigue or sense of impending doom, people have described it as. So if patients have these signs, you want to make sure that they're aware of what they're looking for and to seek medical attention immediately, and to reassure them that a false alarm isn't necessarily a bad thing. If you're having symptoms you're really worried about, it's better to go to the emergency room, get your ECG done, check a troponin, and make sure there really isn't anything going on, and get appropriate risk stratification rather than miss that thinking that it's heartburn and taking Tums all night, which I've had patients do with STEMIs. So as a reminder, 1 in 3 women die from heart disease and stroke in this country, up to 1 in 2, depending on different years, different studies. 1 in 31 women will die from breast cancer. There's a lot of breast cancer awareness, but sometimes heart disease awareness, I think, is a little bit behind. But we know that 80% of heart disease is preventable by what we eat, how we move, how we live. And I think that that's the important part we need to, we need to talk to our patients about, that there is quite a bit they can do to reduce their risk as well. I'm going to share with you the American Heart Association's Life's Essential 8 Steps to Decreasing Cardiovascular Risk. That includes eating better, being more active, managing your blood sugar, managing your weight, controlling your cholesterol, managing your blood pressure, quitting smoking, and getting enough sleep. Because we know people who sleep less than 7 hours are at greater risk for 7 hours a night get significantly greater risk for cardiovascular disease and events in their lifetime. So these are things patients can do to really reduce their cardiovascular risk. And here in Portland, we have Base Camp, which is our cardiovascular and prevention wellness center here, based here at St. Vincent. And we have, lots of wellness tools for our patients and for the community. Our classes are free. We have cooking classes, nutrition classes, exercise classes, and these offerings are also offered virtually. So any of our patients or anybody in the community can join. But I invite you to check it out. It's providencebasecamp.org. But lots of great prevention tips and tools and resources for everyone in our community, whether they're in Portland or not. These classes, we have virtual exercise classes and yoga and things like that are free to everyone in the community. So I want to make sure we share that with our colleagues up in Washington and everywhere else as well. So thanks so much for this opportunity to share about heart disease, women, and prevention. And I look forward to learning from Dr. Isenberg as well, as she's got a lot more to talk about in this topic as well. So I'm happy to take questions now or later.
Thank you so much. Wow, lots of information, Dr. Lori Tam. Thank you for bringing your knowledge and your passion, and what wonderful resources you shared as well through the American Heart Association and also Base Camp. I encourage all of you to check that out too. So we'll take a breath and I will share. And, we know and we think about heart health as brain health, but I want us to think about how, excuse me, I'm going to stop talking and just a moment. Go to my talk. Sorry. Do you see heart risk, women's risk and resilience in heart disease? Yes. Do people see that?
Yes.
Yeah.
Okay, awesome. Okay, all right. So we're going to go through this quickly. And I'm going to, I have no disclosures to make. So our objectives today are to identify and target 5 modifiable risk factors in dementia and heart disease. And what I started to say is that we think of heart disease, and so brain health and heart health is so integrally connected. And that is true, absolutely. And in this talk, we're also going to highlight, I think, some important differences to consider when we're thinking about aggressive lipid management in women in midlife. So we're also going to seek to outline sex-specific effects for ApoE4 on dementia and heart disease. And Dr. Tam did speak a bit about ApoE4 and the effects on heart disease, and we're going to dive into the effects on dementia, and then how to summarize 3 ways that sex and gender factors can guide building of resilience and prevention strategies. So before I kind of review menopause basics, I want to remind you guys that there's a lot of information in prior talks. So I've listed here the first talk by Jessica Caldwell on sex and gender and Alzheimer's disease risk and resilience. And I encourage you all to go back and watch it because it's terrific. And then you may recall that in 2023, with Dr. Linda Mihalov, a gynecologist, we co-presented on women's brain health. And that talk is listed as well. And then there was just last Thursday, a fantastic talk by Dr. Alexandra Pakula, who is a vascular neurologist, who also runs a women's neurology fellowship up in Toronto. And she spoke about empowering women, closing knowledge gaps, and advancing stroke prevention through patient engagement. And the link you see here. And then just lastly, Dr. Sarah Speck and Dr. Rebecca Dunsmore-Sue had a fantastic conversation through the platform Genève on cardiovascular risk and disease in women over 40. So we're going to fly through this pretty quickly, and I'm leaving you with a lot of resources so you can do deeper dives as if you want to learn more. So every woman, if they're fortunate to live through, their late 40s, mid 50s, goes through menopause. And typically with natural menopause, it's a gradual decline in reproductive hormones. However, some people go through it very abruptly through surgery and certain medications. And the average age is 51, and the perimenopausal symptoms can really linger, upward to 10 years in some with hot flashes as and night sweats and brain fog. Okay. So as I said, the average age is 51, and prior to menopause, there's really these fluctuations in estrogen and progesterone, and um, the symptoms range from mood swings to hot flashes to insomnia to night sweats to weight gain, bone loss, increased heart risk, disease risk, increased risk of diabetes, hyperlipidemia, as we just learned. And we know that the neuropathological burden of Alzheimer's disease accumulates, 1 to 2 decades before symptom onset, which typically is in the 70s. And so there's some thinking around menopause as a phase of a woman's life that increases this risk of Alzheimer's and vascular dementia, mixed dementia, decades before clinical presentation. And we also know, and this was spoken about earlier, but now with from the perspective of brain health and dementia risk, um, if you have 2 copies of ApoE4, this is now thought of as a distinct genetic form of Alzheimer's disease. And this happens in about 2% of the population. About a quarter of the population has 1 copy of ApoE4. However, when you look at people with Alzheimer's disease, it's about 15% who are homozygous for ApoE4. And there's some ancestral variability. But what we know, and this is really important in women, is that if women have 1 copy or 2 copies of the ApoE4, they have early onset of Alzheimer's disease and they have a faster course. And we're going to talk about that in a moment. And here you see in this comparative survival analysis for clinical symptom onset and mortality by age based on different ApoE haplotypes. If you're 4-4, you die faster. And if you're 4-4 and you have AD, you die faster. If you're 3-4 and you have AD, you're here. If you're 3-3 with AD, here, and if you do not have Alzheimer's disease and you're 3-4 or 3-3, your probability of survival is thankfully longer. So, and then here you see there's a link to an article about why women experience Alzheimer's disease differently than men, which we're going to kind of continue to talk about. So I see lots of women in the Women's Brain Health Program because they have brain fog, because they have thinking problems during the menopause transition or during midlife. Many of them have a family history of Alzheimer's disease. Many of them actually more and more are coming to me with their direct to consumer genotyping, and they know their ApoE status. Um, so those are kind of the types of people that we're seeing in the Women's Brain Health Program. So what are some additional factors that can affect cognition? So chronic insomnia, we know. So poor sleep, mood, depression, anxiety, family pressures, there's sex effects and gender effects. We're sandwiched. We're likely as women taking care of our parents and our kids. We're have at peak earning power. There's a lot of situational stress. And then if you're having vasomotor symptoms, that can really be very difficult to focus. Sorry, let me go back one. We know that there are changes in verbal learning and memory, as well as processing speed. It's harder to learn new information. And while depression, anxiety, and sleep disturbances are related to cognitive decline, it's not thought that mood or age account for these cognitive changes. Most of these are transient, thankfully, and they resolve after menopause. Okay. I'm going to kind of skip over some of these in service of time. So, how can we manage these challenges? So, what are the things that we can incorporate to help us to manage? And I've highlighted here aggressive treatment of cardiometabolic risks, and that's what I want to speak about today. Of course, it's important to also stay connected socially, to stay active mentally, to be consistent with exercise. I don't know what exercise doesn't help, frankly, to increase our intake of, whole food, plant-based, nutrient-dense, colors of the rainbow, to follow this Mediterranean mind diet, to not smoke, to limit our alcohol, and so forth. But let's talk about cardiometabolic disease. And I'm going to skip over these because we don't have time to talk about it, and we have spoken about it before. I'm just going to say that the current regimen that's recommended is transdermal estrogen, which is considered the safest form because it's not associated with increased stroke risk, and micronized progesterone, which is the most commonly used oral progesterone. And estrogen alone, or unopposed estrogen, of course, if you've had hysterectomy. Some gynecologists are now using an IUD, but it's not really FDA approved in this indication, but many women do have an IUD. Okay, and frankly, there is no data currently to support a regimen for cognitive benefits. So, menopause hormone therapy is currently approved for vasomotor symptoms and bone health. And as we learned, there's some evidence that if used for a brief period of time in that critical window, it may help for heart health. Okay, as I just said. And then vaginal estrogen is safe for most women, for really for all women, actually. Most clinicians would agree. And if you can't take menopause hormone therapy, there are other ways to target and treat menopause, hot flashes and vasomotor symptoms, specifically Veoza. Um, and some, which is very safe for people who have breast cancer or women who are at risk for cardiovascular complications. And you can also use SSRIs or gabapentin. Okay, so the facts and figures just came out for Alzheimer's disease, and as you see here, the lifetime risk for women at age 45 is 1 in 5 and 1 in 10 for men. And while deaths related to heart disease have decreased, deaths from Alzheimer's are on the rise. And these deaths kill more than the combined deaths of breast cancer and prostate cancer. And it's 1 in 3 elders who dies of Alzheimer's or another related dementia. Okay, so we're all very familiar with this, but I just want to circle here in the midlife to highlight that the risk of hyperlipidemia and diabetes and hypertension and obesity and even potentially alcohol increases. So women um, have differential effects from ApoE4 status. They have higher rates of depression and manage stress differently. They have had historically less access to education. They have greater risk of insulin resistance and diabetes. There has been sedentarism in the past in all actually in many people, but um, and the benefits with regard to exercise is that if women do incorporate exercise, there's actually some science, some evidence, some studies that have demonstrated that the benefits are greater. And then, of course, women go through menopause. So to just highlight the neuroprotective benefits of exercise for women undergoing menopause, I've spoken about exercise on virtually every other talk that I've given, but we know that it improves executive function, reduces your dementia risk, can enhance cognitive aging and promote sort of neurogenesis and angiogenesis and improved blood flow. And, um, you know, neuroprotective mechanisms include things like promoting synapses and the irisin and BDNF, and especially in the hippocampus, neurogenesis, as I said. So, women who have one copy of the ApoE4 have a 4 times greater risk of developing Alzheimer's, and if they have 2 copies, it's 10 times. And we know that this risk curve shifts to 5 to 10 times earlier. I'm not gonna. So, what are some sex differences related to ApoE4? So, in terms of Alzheimer's risk, in the risk of if you're postmenopausal and a woman with ApoE4, your risk is much higher. It's increased in men, but lower than women. There is greater buildup of amyloid and tau in women who are ApoE4 compared to men. There's more neuroinflammation in women. As I said earlier, women are prone to insulin resistance, and there's greater mitochondrial dysfunction. So ApoE4 carriers don't clear, as we talked about earlier with Lori Tam's talk, the lipoproteins as effectively. And so therefore there's more saturated fat, so risk of atherosclerotic disease. So hypoperfusion in the brain, microvascular disease, functional connectivity disruptions. Okay. And what are some, I mean, I think we really talked about this a bit, but what's the connection between heart disease, ApoE4, and dementia? So both heart disease and vascular conditions are independent risk factors for dementia, and this is amplified in ApoE4 carriers. And this is synergistic in women. So women who have both heart disease and ApoE4 get this compounding effect. So I think it's important that we start to think about how we might treat women who know their ApoE4 status or who have a family history of Alzheimer's disease potentially differently in terms of the risk reduction strategies. So, how might we um, prioritize these women and implement preventive strategies such as aggressive lipid management or closer monitoring for cognitive changes? Additionally, ApoE4 impacts stroke risk in women. So, women have a heightened vulnerability of stroke when they have ApoE4. It's 2 to 3 times higher for ischemic stroke compared to non-carriers. And that's more pronounced than in male carriers. They have earlier onset of their stroke risk, often seen in the 50s and 60s. And also, there's an accumulation of microvascular ischemic or small vessel disease. So, these white matter hyperintensities that we see on T2 flare signal and potentially microbleeds, particularly in women, contributing to vascular cognitive impairment or vascular dementia or mixed dementia given the stroke risk. Okay. And this decline in estrogen during menopause takes away that neuroprotective effect more dramatically in women who are ApoE4 carriers, creating this steeper risk. Now, we know that the ASCVD risk calculation score does not incorporate genetic factors. It doesn't really incorporate family history either. So I'm posing to us, might we think about reclassification, moving these women who have a family history of Alzheimer's disease or who know their ApoE4 status into a higher risk category than calculated by standard tools, especially if there's other risks present. And whereas Lori Tam spoke a lot about the coronary calcium scan, that really is focused, of course, on the heart. But there is another very sensitive study called the carotid intimal media thickness test, or the CIMT score. And we know that the CIMT score, if it's abnormal, is associated with an increased risk of dementia. So, as you see here, as this reference describes. And so I'm suggesting maybe earlier screening, possibly with like carotid ultrasound or coronary calcium scan or CIMT or vascular imaging in women, particularly if they have ApoE4 and if there's a family history of increased risk. And then, of course, being aggressive with that lipid management. So, how do we promote resilience in these women in midlife? How do we get upstream and really focus on that primary prevention in those women who face not insignificant risk? So, of course, we want to ask and manage stress resilience. There's a fantastic book by Dr. Bergquist called The Stress Paradox that I would recommend for everyone. We want to have community resources and information at the ready. And then, do we really want to, yes, consider aggressive and early lipid management for women with family history of Alzheimer's disease or heart disease or other risks. Okay. Here's our cognitive list, cognitive checklist that we use for everyone. It's not specific to women in terms of the routine labs that we might check. However, so B12 and TSH and lipids, routine studies and A1C. But I'm just asking the community, what are our thoughts about testing for ApoE genotype or a more detailed lipid profile, such as LP little a or ApoB, or screening questions for alcohol and depression are, of course, key, and stopping harmful medications, identifying and treating any perceptual processing abnormality or sleep apnea, and then thinking about these additional imaging studies. Okay, so when we're talking with women about the risk, it's also very important to contextualize in a health span, brain span kind of mindset of there are things that people can do. And how we think does affect our physiology. And I've shown this slide before, but basically this was 4,000 people. It was men and women who were included in the study. And their positive beliefs around aging actually had an impact on dementia incidence over this 4-year period that they were followed. And this was true even in folks who had ApoE4, as you see here. So those who had positive beliefs had lower incidence over time of dementia. So at our center, we also offer these virtual shared medical appointments that are monthly for 8 months, and people are cohorted. They are focused on different areas of health, such as different pillars of lifestyle medicine, growth mindset, physical engagement and mindful movement, nutrition, sleep restoration, positive psychology and social connection, stress resilience, mnemonic strategies, and then lasting behaviors. And, we've surveyed these folks, and 93% say they've improved their lifestyle habits since attending. And as we learned, 80% of heart attacks are preventable. And as we know, 45% of dementia is preventable. Much of that is, of course, medication adherence and lifelong learning in the case of, um, dementia, but also these sustained and positive behaviors. We also have something called FemStrong or Be Strong, which is a user-friendly, all levels online strength training program that has videos, and it's free to our patients to kind of try to combat the sarcopenia that can increase insulin resistance and increase your fall risk. And so to really help people to stay strong both in body and in mind. It's part of our holistic approach that incorporates lifestyle medicine and pharmacological treatment. And here's our kind of prescription, which has, should we be really aggressive about lipid management in somebody who has ApoE4, who has a family history of Alzheimer's disease? And I would say that we need to really think about that. There was a recent huge meta-analysis that came out in JNNP. Actually, it was a multi-site study in JNNP where they compared people who had LDL of 130 or over to those who had 70 or less, and the risk of dementia over time was significantly less in the group with LDL of less than 70. And I think we'll stop now and we can have a conversation.
Well, thank you, Nancy. I really like your question too about whether we should use more genetic testing, because I think there's a little bit of lag in terms of what we can do and it being incorporated in guidelines or day-to-day practice. I think that specialists performing more genetic testing might lead the way for primary care. And then I imagine you're involved in helping create guidelines. So I would like it for the future.
Thank you.
I think, as a cardiologist, I think it's just really interesting learning from you, Nancy, and hearing all about kind of the connection. I will also say I have a lot of patients that come see me, which I recommend a statin because they've got plaque or coronary disease, and they're worried about going on a statin because they think it causes dementia. And we all know studies have not shown that statins cause dementia, but it's kind of made its way into the lay public. And they tell me, I will not go on a statin. I don't want to lose my memory. I've got a family of Alzheimer's. In fact, the data says it's actually more helpful, but I
Yeah.
don't know what I can do to convince my patients other than try to kind of go through the whole, my usual spiel about it with them. But I don't know if you have any other insights how I can kind of be more effective at really promoting treating these patients, and it's not avoid taking statins because they think that it's going to cause dementia.
No, I mean, I think you're absolutely right. It's a huge barrier that people have this false idea that it is associated with an increased risk of dementia when in fact, as you say, and indeed it's been shown in so many studies over so many years now, that it's neuroprotective to have low LDL. It prevents strokes and dementia. And it's anti-inflammatory, as you pointed out, and has pleiotropic effects, so we have so many benefits. So, I mean, I think we try to talk about the neuroprotective effects, and look at, it depends on the patient. Some people like to see data, some people we have shared decision making. But I would say that a lot of times it's just not wanting to take that first pill. Like it's the pill that is the, the first in somebody's experience with the health system. And so kind of talking about that, I mean, it means different things for different people, but you're right that there is also this kind of false idea in social media and so forth that, the statins can harm the brain, which is so wrong and unscientific and not borne out in the literature. So, Barack, do you want to, or anybody else want to kind of comment on their approach? I think it's a conversation, but in my experience, when I talk with people about it, most of them, and especially when we use kind of teaching tools and they can see the Lancet, and we'll like use this and say, you see this LDL, and if we can, this is one of the risk factors that significantly affects your midlife risk. And they come to me because they want to do anything and everything that they can to reduce their risk of dementia or to prevent it. Usually that's helpful, and it's hard. Brock, do you want to?
Yeah, I would just say like statins are extremely safe, and I think that it is there's very low barrier to thinking of starting anybody on a statin. Really, like I think the data is so compelling and the risks are so like hard to exactly sort of find, and now that the medications are so inexpensive that I spend a lot of my time convincing people that they should start a statin.
So I really hope I hope that I hope our community can think about that as well, and can sort of, now that we know how it's neuroprotective, it's cardioprotective, there are so many benefits, so little risks, it's so affordable. Yeah. Okay, I'm gonna, in the last 30 seconds here, let's see here.
Question.
Yes, Alina.
Thank you. For those patients who have low or borderline risk, but we're using a statin for neuroprotection, what is the dose range? I mean, we know the dose for cardioprotection, but I don't know what the range is for neuroprotection.
Well, this is an art of medicine question. But I would say that using I will answer what my perspective is, and then I welcome, I would say starting with a high intensity like 5 of Crestor would make a lot of sense. And Lori's nodding. And there's a beautiful up-to-date curve that shows compares the statins in terms of benefit and how well, by what percentage they're likely to reduce at the population level, the LDL. So you could take a look at that. We can share that actually out here. I think that's a great graphic to share as a teaching point when you're talking about incorporating statins. Well, we are at time, guys. We're beyond time. So thank you. And we had a lot to cover. There were 2 speakers, so we very much appreciate you sticking around. And we have a fantastic, I think I'm not going to show the slides, but please do complete the 1-minute survey. And Dr. Sylvia Russo is speaking next time about Lewy body spectrum disorders. And we hope you can make it. And happy Mother's Day and happy weekend. Thank you. See you next time.